We are live. What up? What up? What up, Coy? What up, Derek?
What's going on?
What's going on with y'all?
We're good, quiet, man. Derek. I made it.
Derek got on mute.
I made it this time.
Hey, we knew you were busy last time. We knew that.
I totally whiffed on last time. I apologize. Yeah, I'm glad. Thank you, sir.
So we're just gonna wait for a few more people to join us. That's pretty much. We'll wait for a few more people to join us. We got a special guest as well. Dr. Whiteside will introduce our special guest for our wonderful topic today, which is PCOS. So we're actually going to talk about it. Didn't realize during the research how common it was. I was shocked by that. So, and it's interesting because, hey, Urban, how are you? What up, Walt? So it's interesting because I didn't realize how it affected so many people. I didn't realize that. Then on top of that, diet, which we want to talk about, metabolic syndrome, things of that nature. So yeah, it's very interesting. It is very interesting when it comes to that part.
Yep.
Here we go. Okay. Try to make sure I get everything up together. Wait till we get a few more people on. So what's going on today, Walt? What's going on, Urban? How are y'all today? Hopefully everything is good where you all are. Walt, I got to get with you. So yeah, I got to get back to training as well. What's up, Bio? What's up, girl? Hey, it's all good. Hey, look, Bio, we understand everybody's busy, so we truly understand about that part. Totally understandable. We got a good topic today in your avenue dealing with nursing, talking about PCOS. Waiting on just a few more people. Everybody just come on and get comfortable with it. Come on and get comfortable. I need to, when y'all give me a chance, I know Erica was fussing about this last time. She always said, I pretend I don't know what I'm doing. I forgot to drop the actual PowerPoint. So y'all give me a chance to do that as well. So give me a few minutes for that. Dr. Whiteside, did you want to go ahead and take it over real quick when it comes to this?
Yes. What's going on, everybody? We got a good presentation today. We got one of our OBGYN comrades that's going to join us, Dr. Letitia Lyons. She's been doing OBGYN for, I got to ask Tish for sure, I think almost 10 years.
Over
10 years. There she go. Hey, so she's going to be our really our SME for this presentation. So, Dr. Lyons, go ahead, introduce yourself. I did a fairly poor job, other than I can go in and start talking about acupuncture.
You could, but that's all right. I'm a pro at introducing myself. So hello, everybody. My name is Dr. Letitia Lyons Watson. I am a board certified OBGYN. I currently practice in the Air Force. Right now, I've been taking a year hiatus to do some professional military education. But this summer, I will be getting back into the clinic, not necessarily full time, but more than what I'm doing now. And so I graduated Meharry Medical College in 2014, did my residency at the University of Texas at Houston. And then from there, started my military life. And so I have really enjoyed the military, but I love OBGYN a lot more too. So I'm happy to be here with you guys tonight.
Oh, you said Meharry. Okay. So how'd you like Meharry?
Loved it. Okay. Highly recommend.
Okay. Tell us about the experience. I know we're about to be off topic, but okay. We just want to learn because they know about us. So yeah, tell us about the Meharry experience, the Nashville experience.
It was excellent. So I went to undergrad on a full athletic scholarship at a PWI institution, Old Dominion University. And I knew that I did want the HBCU experience. And so I did apply to different schools. Ultimately, I got into Meharry through their post-baccalaureate program. So I got accepted there. I met the prerequisites of the GPA and MCAT score and was admitted and then matriculated from there. And it was wonderful. The instructors were amazing. They were highly invested in us. And Meharry is smaller, so we actually got to be hands-on, especially when it came to clinical parts. So I loved it. And Nashville grew on me. At first, I was like, not feeling it, but it actually is pretty nice. And now it's grown leaps and bounds. So I'm happy that I made an investment there with a purchase of a home. But it really was a special place.
Yeah, because I know for my students, we take them to Tennessee State, which is pretty
Mhm.
much down the street from it. So
Down the
we
street.
we
Mhm.
actually did a visit there at Tennessee State,
Okay.
and they happened to go past Fisk, and I was explaining to them about Fisk University and how Meharry's literally right across the street from it. So we were
Mhm.
talking about that as well. It was just interesting because I teach healthcare, and a lot of my students want to go into nursing and medical, and I'm like, there's other things besides nursing, doctors. There's other avenues in the medical field. So I'm just trying to open up their eyes, and I love the fact that you actually went to Meharry. So that's pretty
Yes.
cool because I don't know that many that went to Meharry per se, but living in Georgia, everything here is Morehouse. So everybody talks about Morehouse Med School. So, but I love the fact that you actually went to Meharry. That's pretty cool. That's
Yeah.
pretty cool. I like that.
Fun fact, I actually stayed at Fisk, the summer program of our post-baccalaureate program before I moved into my home. And so that was an interesting experience. But I think they probably still do at Fisk have a pipeline program, undergrad to MD. And Meharry used to have a nursing school, but they don't anymore. But I believe they just opened a PA school. So they're doing a lot of big things there. They're having, I think they just opened a global college of international health as well. And so, yeah, I just love my school.
That's what's up. And you said ODU? Man, I lived in Richmond,
Old Dominion
Virginia.
University, yes, yes.
So I know what ODU is.
Mhm.
And Derek told you we actually did a pre-med internship at Fisk University between Fisk and Vanderbilt. We actually
Okay.
that was my first experience there. He wanted med school. I didn't want med school. I was just going for the ride. I like if you're gonna do it, I do it too. So I was just going for the ride. So it was a good experience. It was a good experience.
Absolutely. Loved it.
Derek, what's wrong with you? Derek look all confused.
Sounds like a smoke and stack moment.
No, I'm good, man.
Yeah. Ain't go see Sinners yet? Oh, never mind.
Nah, that's on my list. That's what I was talking about.
I'm trying.
Yeah. You'll get it later. Go see Smoke and Stack. Go see Sinners. You'll get it later.
Okay, we'll do that. All right, so with that said, we're not going to hold up anymore. So today we're going to be talking about PCOS, and I actually have a PowerPoint to go with that. Of course I do, because it's me. Now I'm trying to figure out how I can share it because, again, I struggle with technology for some reason. Let me see. Nope, not this one. Y'all bear with me. There you go. Okay, there you go. So with that said, we're talking about PCOS today. Break it down for you when it comes to PCOS, and Doc, she's going to actually hit it on. And, matter of fact, Doc, could you take this over right here? Since you're familiar with this, I'm not going to step on any toes. I'm just going to play moderator. So go for it.
All right, perfect. So PCOS, that is the acronym that stands for Polycystic Ovarian Syndrome. And the way that I explain it to my patients is it's basically a metabolic disorder of unknown origin. However, it is pretty common with about 5 to 10% of women experiencing this phenomenon. There are several different symptoms that can go along with that sometimes don't make sense until you go and see a physician. And because of that, it can be pretty underdiagnosed. And so, some patients just think that their periods, the way that they are normal until they come and see me. And I say, no, that is not normal. So that is essentially what it is. And I think we'll get into in the next couple slides how to diagnose. Perfect. So again, going back to kind of those symptoms, this slide shows a mix of symptoms as well as clinical signs. So insulin resistance, meaning that the cells are not being sensitive to insulin, which is a hormone that helps the cells collect glucose. Definitely irregular periods is one of the signs, and they can either come too few, meaning that your cycles are 35 days or more, or you may not have a period at all for months, and then all of a sudden it shows up. Again, you can have slower metabolism, increased weight gain, difficulty losing weight, extreme fatigue, and excess androgen, which takes the form of excess hair growth either on the face, on the chest, around the nipples, or even in the pubic area where it extends beyond the area on top of the vagina onto the inner thighs. And so here are a few myths about PCOS. Number one is that people did something to cause it. Like I mentioned in the intro, it's a disorder of unknown origin. So we don't know how it happens. And so therefore we can't say, oh yes, you did these things. This is why you have PCOS. Number two, if you lose weight, you can get rid of PCOS. Not necessarily, but losing weight potentially could help improve menstrual irregularity and all of that, which we'll talk about in a few slides. Next, PCOS is a rare condition. As I mentioned before, about 5 to 10% of women actually have it. And because it's underdiagnosed, that number actually may be a little bit higher. So it's very, very common. I actually see it, if not every clinic, every other clinic. Even as I've been practicing here in school, I've had clinic every other week, and I've had at least one patient every month who I've had to diagnose or take for further testing to confirm what I suspect. Myth number 4, you can't get pregnant if you have PCOS. Fun fact, I have PCOS. So that is not true. I have a little boy who's trying to go to bed right now. But it can be more difficult for patients to conceive and carry a child to term if you have PCOS. And we'll talk more about that as well. Last, PCOS only affects overweight women. Now, this is in the classical definition, patients who are overweight or obese. They are categorized as having kind of PCOS features. But as I've seen, especially since I've been out of residency, I have a lot of patients who look fit. They are not obese, and they have PCOS based on the diagnostic criteria. Okay, so jumping into a little more about the signs and symptoms. So patients can have acne, they can have infertility. I mentioned before weight gain or trouble losing weight. Hirsutism is associated with those increased androgens that I was talking about. So that is increased facial hair around the face, chest, nipples, and in the pubic area. Hyperpigmentation, so that is where you have skin that's darker on certain places as opposed to the rest of your skin. So this can kind of go hand in hand with insulin resistance, because one of the signs of that is a medical term called acanthosis nigricans. And so that is where you can have dark spots either on the back of the neck, you can have them in your elbow, you can have them on your knees, and those are some of the signs that you can see as well. Irregular periods, as we talked about, that's kind of one of the hallmark symptoms. Ovaries with multiple cysts, that's kind of a more clinical thing that we get to once you come and see a physician in the office. And then high levels of androgens, again, that goes along with the hirsutism. So I think we kind of hit that one. We can move on to the next. Okay, and I think I've hit that one too. All right. So go ahead.
My bad, because I know, let me pull this back up real quick here. All right, so Bayushik, she just said this earlier, was just talking about PCOS and its relationship to insulin. Can you hit that? I know we talked about androgen excess. Can you hit the insulin resistant part of it? Because that's very interesting. And then I want to have Dr. Coy, because again, we talk about type 2 diabetes, things that are the metabolic syndrome. Doc, we get you first to hit it, then we get Dr. Coy to talk about that part as well.
Sure. So again, there's not a whole lot of information that we know for sure about the actual mechanisms of action and how PCOS contributes to it, because it is a metabolic syndrome that is still being investigated. And so we don't necessarily know. What we do know is that patients who do have PCOS are more prone to having insulin resistance. And so when we're counseling patients about how to mitigate those factors in the future, like their risk for having prediabetes or even diabetes. Talk a lot about diet and making sure that they're exercising so that they are able to kind of decrease that risk, although it still may not decrease it enough to where a patient ultimately gets insulin resistance or diabetes.
Dr. Coy?
Yeah. So, from a functional medicine standpoint, yeah, I mean, polycystic ovarian syndrome is it's a common condition that obviously affects many women in the United States, and it's very challenging for individuals that are really trying to have kids. But the other aspect of it is that there are some cardiovascular issues that can come about from it, and it's also related to metabolic syndrome. So when we talk about metabolic syndromes, it's all about the body's ability to create energy. And just like what the doc just said, is that when we have problems with these with polycystic ovarian syndrome, it's a hormonal imbalance. And one of the major hormones that we have is insulin. Just like the doc said, with insulin is there to help us to collect that energy, to collect that glucose and accept that glucose into all the body cells. But when we have these issues with polycystic ovarian syndrome, it mimics that insulin resistance component. And unfortunately, it creates an imbalance to where people or females are not able to have that energy or to be able to accept that energy into the cells of the body. And so when we look at it, it's just it affects many women at their reproductive age, that irregular menstrual cycle, all of those things. And so for me, it always comes back with the proper testing to make sure that we're doing a thorough hormone panel to see not only just the insulin, but also looking at your testosterone, your estradiol, you're looking at DHEA, we're looking at all these hormones, how they play a role with each other. And hopefully, as you're able to see what other hormone resistance and deficiencies that are there, you're able to put those in balance and allow the body to get back to some homeostasis.
Good question. One question I have back, because I know we talk about insulin resistance. So when we talk about insulin resistant, what about people who are, or females who are suffering from type 1 diabetes? Because we know we got an insulin problem already. So is it more difficult for females? This go for all of you all docs on the panel. Is it more difficult for women? I guess when it comes to insulin, just women in general, is it more for them? How do I say this? They suffer more from fatigue, or in this case, like what says other hormones, lower sex drive, or what exactly? If that makes sense.
Well, let me jump back into the metabolic syndrome thing.
Yeah.
So metabolic syndromes are very common, especially with individuals with PCOS, due to insulin resistance, and that is all associated with a myriad of different conditions. One is high blood pressure. One is high cholesterol, high triglycerides, we talked about high blood pressure, but also just excess of gaining weight. So the way I look at it is those things are symptoms, right? They're symptoms that manifest themselves to show that there is an imbalance. And again, when we look back at PCOS, this is another hormone imbalance that involves insulin and the androgens, as well as the estrogens as well. And so when all these are imbalanced, and there are numerous reasons why they're imbalanced. For me, I'm always looking at many of these, many toxins in our environment. They're hormone disruptors that cause these things, and these things can, especially with PCOS, these things can come about really early in a female's life, leading up throughout their life as they're approaching their childbearing years. And so it's very interesting to be aware of the symptoms and be aware of these challenges that they have in order to create a plan of action to help them to recover from it.
Doc, did y'all want to add to it? Say anything?
No, I just want to say, I think that's an interesting point that you made, Dr. Coy, about the toxins and everything, because we truly do live in a different age in America where there's tons of processed, ultra processed foods that are consumed, if not on a daily basis, definitely more than once a week. And so if we compound that from exposure from little girls up to adulthood, definitely I can see how that can play a role.
Yes, it's amazing to run panels, and these oftentimes are tests that are outside of the traditional medical model, if it's not covered by insurance or anything of that nature, where females are beating their head against the wall because they know that they're not well, they know they're having issues with fertility, and they're not getting the answers. And then we pull panels, hormone panels, and it lights up like a Christmas tree with the imbalances. And then the other side is the toxins. We're talking about heavy metals. We're talking about mold. We're talking about, just environmental toxins, that even the air that we breathe in. I don't know if this is true or not. I was talking about some plant in Tennessee that's with Elon Musk, some plant that's pushing all these chemicals into the air, and in the Nashville area, these things they're gonna have an impact. They're gonna play an impact on the surrounding area and the people in their future. And so these things are always going on, the food that we eat, and taking account of these toxins that many of us have a susceptibility to them, and we don't have the strong enough immune system to get rid of them. And so it's very interesting to really look at those things. In some ways, like PCOS can be the tip of the iceberg of many other factors that can come about. So it's very, very interesting. That needs to be looked at in our females from the time they have their first period all the way up to menopause and beyond.
Okay. Here it says, Body Sugar said, question for you when it comes to this. Based on your perspective, do you think decreasing added sugar consumption can reverse PCOS? Because we know we've talked about that before. There's been studies about the decrease in the sugar consumption, decrease in caffeine, decrease in chocolate, and basically carbohydrates in general. So what are y'all views on that part?
I don't know about reversing PCOS, but I think it potentially could definitely help with decreasing the adverse effects of PCOS, such as the insulin resistance and or diabetes, and the consequences of having those things together, what we're talking about with the metabolic syndrome and all of that. So I don't think it necessarily would take it away, but it can help mitigate some of those side effects.
Dr. Whiteside, Dr. Coy?
Well, I think that sugar helps, or eliminating sugar, especially things like fructose, helps a tremendous in tremendous ways. When you're having that, like fructose, is going to cause oxidative stress, and that's basically just walking you down the path towards cell death, and it damages the cells. You're not able to process things, and it inhibits your body's ability to create that energy. So those cells, and even hormones, the hormones are just messengers to allow the cells to conduct the functions that they're supposed to do with the way they're designed. And so definitely staying away from the sugars is very much important. You're talking about fruit juices, your cane sugars, your high fructose corn syrup, in a lot of ways, even honey for some people. it can be very destructive. The nectars, the wheat, the grains, a lot of these things can turn to sugar, and the body's not able to process it very well. So it can help in a myriad of different ways. But in this particular case, if you're having issues with insulin resistance, you don't want to compound that with a whole bunch of sugar at the same time. It's not a good combination. So, trying to really mitigate that and limit that is very much important.
Carbon talks about women heading into perimenopausal that have PCOS experience a harder transition than other women.
That's a very good question. I will be honest and say I'm not sure of the answer, just because, like we've mentioned before, it is already a hormonal imbalance. And so potentially, if we're talking about compounding effects, but I would have to look into the literature to get a definitive answer on that. And there may not be any literature out there.
Okay. Makes sense. Dr. Whiteside, you got anything? Because you staying on mute right now.
Oh, nah, man. They've been going at it. I love it. I'm over here trying to take notes.
Question for you. So here we talk about other potential factors. So we talk about early puberty, because we talked about this earlier, how females with the hormones in the diet and everything, females or little girls are actually entering puberty earlier. So it says here, girls who develop underarm or pubic hair before the age of 8 may be at a higher risk. So are you noticing this now, that more females or more girls prior to becoming adolescents are hitting puberty at an earlier age? Because I know from some documentation I read, it's been as early as 6 or 7 years old they start a menstrual cycle. So that's kind of scary, considering 20 years ago it wasn't like that. Right. So Dr. Weiss, do you notice that's going on now?
Did you say Dr. Whiteside or me?
Nah, not me. You. He skipped over me, girl.
Nah, he was the last one I asked.
So, in my practice, ironically, even in residency, where we have a high volume of cases from all over the spectrum, I really did not have a lot of patients who young girls who were brought in by their mothers saying that, they either had their period or they're noticing breast buds and all of that kind of stuff. But I think that may be more on the pediatric side, but there's also adolescent gynecologists who, or reproductive endocrinologists who may see more of those cases. But as you alluded to before, there are studies that have shown that there is a trend among that, particularly in Black women or Black girls and other girls of color.
Anybody else want to add to that? Anybody else? No,
I'm good.
Well said.
Okay, moving on to the next thing. Question here. So it says the 4 types of PCOS, and when I was doing the research, this is very interesting. Yeah, your 4 types. We did talk about insulin resistant PCOS. Now, jumping into number 2, inflammatory PCOS. We Dr. Coy talked about this all the time when it talks about dealing with inflammation, types of food, and things of that nature. Doc, for you, can you expand upon inflammatory PCOS? Break it down and explain exactly what is that.
So let me just read it right here. It says this type is linked to chronic inflammation, which can affect hormone balance and lead to various symptoms. Inflammation can cause joint pain, headaches, skin issues like acne, eczema, and gut problems. So that's my world that I live in. It's looking at inflammation and how it's affecting the body. And we have to understand that inflammation is an immune system response. So it's one of our first lines of defense. It's a way for our body to tell us something is wrong or to deploy resources for healing. Unfortunately, if the body is not able to take on that burden of handling inflammation, and inflammation can come from different sources, different ways. Our bodies are beautifully, masterfully made that we respond to our environment, an internal and external environment. And so when we see these things, like these symptoms that come about as a result of inflammation, like joint pain, or the itises, all these itises that come about, and when we see that or feel that, that's a sign that the body is imbalanced. And so it's just so interesting to see how this can cause these hormone imbalances, because the body is always trying to find a way to compensate with a lack of, or if something is too much, is trying to compensate to bring it down, and there's going to be a disconnection there. And so even moving on to number 3, the adrenal PCOS that is associated with stress, like stress, that's a major thing. I think we talked about this in other episodes, is that stress can come in different ways. It can come physical stress. It can come with mental, emotional stress, and it also can come with chemical stresses. So all of these things are, in my world, they're coming from the same root. They just manifest themselves as different fruit. They come from the same tree, but they manifest themselves as different types of fruit. And so when you see these issues, and these are the type of panels or type of hormones that I'm looking at, like cortisol and DHEA, which is an anti-aging hormone. It helps you with immune system. It helps you with, these are the byproducts of sex hormones. So we see these hormones, the great grandparents of your testosterone and estrogen and progesterone and all these things. These obviously can come from adrenal stress. So that's where you got to have the fatigue. That's why you're going to have the anxiety, depression, and obviously inability to handle stresses of life. So I've never looked at it like from that standpoint of breaking it down in that way, but it makes perfect sense.
Yeah, and I think particularly for 2 and 3, we're going to talk a little bit about the disparities amongst the different racial groups. Yes. I think when it comes to women of color, particularly Black women, it kind of goes back to what I was talking about before. It's kind of baked in. And so there is something called the weathering hypothesis. So having consistent stress or being bombarded with things such as microaggressions or other things can slowly weather you to the point where, you end up having these kinds of disorders or other things that manifest. And so I think those two are pretty important.
Okay. One thing I want to post to the chat real quick, and I said, this question is for the chat. Why do you think it's important to check hormone levels with blood tests? So again, I know the doctor's going to jump on this real quick, but for the chat, because I want to make it interactive. Why do you think, Urban already answered one, but if anybody else is there, feel free to answer. Why do you think it's important for you to check hormone levels with blood tests? Y'all get time to go ahead and put your answers in if you want to talk. It doesn't bother me. Urban said right here, blood work paints an accurate picture. How we feel may not be accurate or reflect what's happening inside, which is true. We did talk about that before. You may feel good on the outside, but on the inside, you're not feeling it. So that does make sense. So anybody else, what else do you say? Why is it that you should actually test?
Bayou just said something.
Gotcha. Says checking hormone levels, I think, allows you to see additional signs and symptoms of other diseases that basic tests won't indicate. Good one. Okay. Anybody else? Because Garvin says she agreed with I like with Urban's. I like that, because if you notice, the common denominator here is painting that picture. And Dr. Cole, you said that before. Mm-hmm. That blood test paint the picture. You get to the root cause, because a lot of times, not saying you all, but a lot of medical professionals, is a Band-Aid thing, and you don't want to do the Band-Aid. You want to get to the root cause. What is truly causing this issue? And actually nipping it at the bud will help relieve other symptoms that may compound it. So, Dr.
Yeah, I mean, again, if we look at, we should embrace symptoms because they give us indications of the imbalance. We don't like to feel them, we don't like to experience them, but they do give they give a picture or a window into what's happening, and it's up to for that clinician to really take it a step further to do the proper diagnostic testing. Blood work is one, and there are numerous types of other panels and tests that can be done with testing saliva, testing urine. All these factors have their pros and cons to each one, but you just got to make sure that you're testing something to give you a picture of what's happening based on the symptoms that the patient is telling you. So so doing the proper testing, blood work is pretty much routine, but it's still looking at the various panels, looking at various markers of a person's hormone, how they relate to each other is so important. So sometimes patients are getting pushed aside because when we talk about first health disparities, being marginalized, being minimized based on their symptoms, and sometimes even basic panels, when they run those basic panels, they're pushed aside because those look normal, but the patient is saying they're not feeling well, right? Mm-hmm. And so those conflicting measures, sometimes patients are pushed aside and left to suffer until they are with someone that's willing to go deeper and look at their health and take their health a little bit more seriously. So it's important to look at those things and make sure that you're not taking no for an answer if you're feeling the way you're feeling with all these symptoms that are coming about.
Yeah, I agree with you. I'm looking at, it was kind of funny because I had a patient today that was complaining of abdominal pain for the last probably 3-4 years. We finally decided, said, you know what? You just finally saw me. Let me figure out what's going on. You saw other providers. They ordered your basic CBC, CMP, nothing really, trying to figure it out. I said, let's just do a transvaginal ultrasound. Let's see what's going on with that. Transvaginal ultrasound shows polycystic ovarian. I said, all right, you got a bunch of cysts on your ovaries. We know what's going on with there. But the great thing is that she was actually working with an endocrinologist as well. She didn't get set up with Women's Health. So I told her, let me put in a referral for you to see Women's Health. Because from an internal medicine standpoint, there is only so much I can do for this disease process. I need my specialist to actually weigh in and assist me with this.
Mm-hmm. All right. There, you jump straight into it because that was the next slide. Dr. was laughing because that was actually one of the slides we were going to talk about too, because I actually had some good questions and Shannon actually had a good question as well. We're going to jump straight into that in a second. Doc, you did talk about the racial and ethnic differences. So we talked about that earlier offline. And here, the biggest thing, which is very interesting, is 70%. It says 70% undiagnosed case, which is scary. It says a large percentage, potentially up to 70% of women with PCOS may not be diagnosed. Mm-hmm. Now, what is your take on that?
I would say I'm not surprised. This is kind of similar to endometriosis. There's a study out there that shows that patients who end up getting diagnosed with endometriosis, the mean time from like symptoms to diagnosis is like 10 years. And so I think that's a combination of several different factors. One, potentially doctors are not listening to the patients or brushing aside certain symptoms. Two, potentially patients thinking that what they're experiencing is normal. As we discussed offline, I can't tell you how many patients that I've had just for not necessarily PCOS, but for abnormal uterine bleeding, for instance. They're like, yeah, I change my pad every hour. I just deal with it for the first couple of days. And then, I'm usually good to go, but I have to stay at home because I have, accidents and all that kind of stuff. And I'm just like, how long has this been going on for you? Sometimes they say years since I've had my period start. And I'm like, that's not normal. And it's only until I say that's not normal that they realize, oh, maybe I need to do something about it. And so I think it's a combination of different things. And I'm not surprised that number is super high.
Well, what's funny? I wonder, just coming from a male perspective, who actually listens more to what's going on? Is it the male provider or is it a female provider? And I'm just saying that from the standpoint as a male provider, especially with me, I have no clue. If you bleeding, okay, I understand you have your menstrual cycle. I cannot relate to it. All right, if I have a female that comes up to me say, well, I'm changing my pad every 2 to 3 hours. Okay. Are you soaking the pad completely? Yes, I am. You know what? All right, something's going on. I don't know that part of the region. Let's go ahead and get you taken care of. And I get picked out by Women's Health because I'm ordering every scan, everything I could think of, because I said, something's going on. This is not normal. Let's get you taken care of. I try to be as complete as possible before I send it over to a specialist, because the last thing I want a specialist to do, and doc, you know it, I send somebody to you, be like, well, where the hell is everything? You ain't do this, you ain't do that. You know what? I'm ordering everything. If you don't like what I ordered, great. I'm looking for zebras because I have no clue. Here you go. Figure out everything that I've done. There are some women who I know they will just deal with it. But for me as a male provider, I'm thinking, yeah, no, this ain't normal. If you're complaining about it, you got the belly pain, let's figure it out. Let's go ahead and push forward. I've seen some of my colleagues that are female providers, they actually kind of push it off and says, you know what, it's just your cramps, deal with it. I'm thinking, you have more experience with it than I do, but are you really listening to them? Are you not? How is it? I'm not in the room because I'm actually curious as well to see if the color makes a difference, because I know for the black population, tough it out, deal with it. No, we are all dealing with pain together. Let's figure out what the hell is really going on.
I agree. First of all, let me applaud you for ordering things, because that helps when the patient comes to follow up. Because usually once a patient comes to me, more times than not, we're starting from ground zero. So then I have to get the history, which I'm getting regardless, but get the history, then order all the labs, then order all the ultrasound. If we have all of that stuff to begin with, then we can have a more fruitful conversation at the very beginning. So kudos to you.
I appreciate it.
I think the other thing is that it can depend. So I think there are female physicians who blow off patient symptoms. I think there's male physicians that blow off patient symptoms. The other thing that we've kind of been talking about this entire presentation is the makeup of the physician. And so we know that there's a few studies out there that show that patients who are taken care of by Black doctors or doctors who look like the demographic that they're treating, they have better outcomes. And so I think that also plays a role, because, you know, there is bias in the world. And so there may be some physicians who are not the same race as another, as a patient that they're treating, who may not necessarily overtly think, oh, I'm just going to blow off their symptoms. But because of the biases they have, they just simply ignore it.
One thing here, I love this interaction. Boy, I feel special now. I'm gonna go to med school now. Okay, I'm not. I'm too lazy. But anyway,
hey, you was offered the opportunity.
Why you do that quick?
Now, don't even try that.
I'm playing my video games. All right, so in the bottom right here, it says the study found that Black women and Mexican American women experience greater high insulin levels and high insulin resistance than white women. And we talk about that offline as well. And it says, yet, despite this significant difference, research remains limited. So they're talking about there's not enough studies. Many women of color report not being taken seriously, which y'all just talked about. They're not being reported not taken seriously or properly tested when seeking care for PCOS-related symptoms. And I love the way that, leave me alone, Carmen. I love the way that all you all hit that. It's like, it's the makeup. And that's one of the biggest things. And then it says, because Black and Latino Hispanic population already experience higher rates of morbidity and mortality from cardiovascular, which Dr. Coy was talking about earlier, and diabetes, understand racial and ethnic differences in how metabolic syndromes, which you hit again, presents in women with PCOS is critical for developing effective preventive and treatment strategies. That's one of the biggest things. And Doc, you did talk about that, is the makeup of the physicians. And one thing we talked about earlier is if you don't get your results, fire that one, find another one. Find one that will actually listen to you. So I love the way that you all actually hit all of this. So, and I like how the crowd is saying too, kudos, because that's one of the biggest things.
Let me bring up, sorry.
Yeah.
Tampa Creek, if you can pull up her comment.
Hold on, let me see. Here we go. Nope, wrong one.
I made you hooked on phone.
There we go. I got you.
So I'm not gonna lie, that's a pet peeve of mine, is surgery. I hate surgery because, especially in the pelvic region, once you start cutting, I'm afraid of adhesions. And they, from what I've seen, will develop fairly quickly in the pelvic region. I hate the fact that they went straight to a partial hysterectomy. My thing is that I'm kind of wondering, did they actually go in deeper detail to figure out what's going on? When you talk about your periods, I'm also wondering, was it actually endometriosis that could have been the issue that they didn't really work up completely? I'm on the aspect that when it comes to women's health, I try my best to know as much as I can, knowing my level of knowledge is limited other than in the books, and making sure that I have a specialist follow up with you. I prefer the providers, and I'm going to let the people know that I prefer the people or patients to see providers that will actually sit down and get to know what the hell is really going on. If we keep saying it, all of us said it at the same time, if your doc is not sitting there listening to you, you have the right to get up and leave. If they're trying to tell you what is wrong with you, they are not living in your shoes. They are not living in your body. You can get up and leave. You want to be able to speak to somebody that's going to actually listen to you. I can let you know, not every provider wants to go straight to cutting. Some of them do because that's how they make their money. But there are other providers who prefer to figure out alternative options. Somebody else said in the chat that they were just placed on birth control. I'm trying to figure out who that was.
I got you. That is
Edwards.
Yep.
I would say I've done that before where I'm trying to figure out what's really going on. In the meantime, if I can put you on birth control to try to control some of the issues you have while you're going to get seen, that's what I would do. But also let people know at the same time, I'm introducing another substance in your body that will affect your hormones. And I'm very mindful of that as well. So I was like, yes, I can put you on birth control. Let's see if this will help control your periods, because it might be 3, 4, 6 weeks before you can get in to see GYN. So let's try something other than nothing.
Yeah, I like that. I always approach it from the perspective of just having a conversation. Like, I truly believe in shared decision making and making sure that my patients are armed with all of the knowledge, all of the options available at their disposal so that they can make an informed decision. And I always tell them, especially when I'm talking about, let's say fibroids, for instance, there's a lot of different options for that. And we go through every single one, risk, benefits, other things that they can do. And I tell them, I say, hey, we don't have to make any decisions today. You can go home and think about it. I'll write out everything that we talked about. You can go home and look it up. Yes, I do give them permission to go to Dr. Google after they've talked to me, though, so that they can make the best decision for them. I'm not a person who likes to jump immediately to surgery as well, because there's risks associated with that. Yes, techniques have improved. But at the same time, there are long-lasting effects, especially for patients who end up getting hysterectomies and then getting their ovaries taken out, especially if they're young. Like, I have a case that has kind of haunted me from residency, where I felt like I could have advocated more for a patient, but she was 35 and ended up getting a total hysterectomy, meaning that her uterus and her cervix were removed, and she had a bilateral oophorectomy, which is taking out both of the ovaries at 35. Now, we put her on medication, hormones after that, but still there are significant risks for doing that to patients premenopausally. And so if I had to do it over again, I would have given her some more counseling. I ultimately did not do the surgery, but I did talk her through that whole process. And so that definitely taught me to listen to my patients, have that conversation and tell them, hey, you're in charge. My job is just to tell you everything that's available to at your disposal. What I can recommend things, but ultimately you are the boss. And so I want you to be informed.
Good one. Jump to the next thing. I love this. Oh boy, I'm telling y'all. I love this. All right, so here we're talking about what to expect during your evaluation. So medical history, symptom review, and physical and pelvic exam as well. And one thing I want to pose to the chat is, I'm gonna copy and paste because I'm lazy. And I'm going to actually say it as well. Y'all give me 1 second. I know y'all like, this boy do the most. All right, so here it says, what's one word you think of when you hear the word pelvic exam? And notice that's that second part, physical and pelvic exam. So females, guys, yeah, we out of this. I'm sorry. But for females, what is one word you think of? What is one word that comes to mind when you hear the word pelvic exam? Honestly, for me, I just hear cold instruments or cold hands. That's all I hear, because I hear that a lot. But for the chat, what is one thing that comes to mind when it comes to this part? And I give y'all time to actually just post that in there. Oh, go ahead. Got it already. Discomfort. Okay. I love that. Okay. We have STD, sexually transmitted disease. Okay. Makes sense to me. Good ones. Good inputs on that. For me, it says, for medical history system, your healthcare provider will begin by asking about your personal and family health history. Doc, could you take this over? Because again, this is your bread and butter. Can you talk about this part? Because I know you hit it earlier.
Yes. So definitely the first thing that I do when I'm evaluating a patient is take a thorough medical history. So I want to know everything about you physically. So I want to know if you've been pregnant before, how many times, what route did you deliver your babies, if you had any miscarriages, if you've had any surgeries. For your GYN history, I want to know when you started your periods, how much time is between your periods, how long they last, the flow, if there's any history of abnormal pap smears, any history of STIs, sexually transmitted infections, contraception, all of those things I want to know, in addition to the other history that is traditionally taken by other colleagues, such as Dr. Whiteside, like your past medical history, your medications, allergies, et cetera, et cetera. And so at that point, after getting all of that, and I must say that I don't necessarily get to the medical history part until I hear from the patient exactly what is going on. So start out by saying, hey, what brings you in? Or I see this is why you're here to see me. Tell me from the beginning what is going on. So based on that, then I can interrogate you a little bit further to try to get more information about your symptoms. And then I jump into all of those things. At the conclusion of that, we go ahead and do the pelvic exam. And one distinction I want to make, because I think that's a good question that you asked to the chat. What do you think of when you hear pelvic exam? I do want to make the distinction that a pap smear is not always done every time you get a pelvic exam, because sometimes I have patients and they're like, yeah, I just had a pap smear. And I'm like, did they actually check your cervix for cancer? If they didn't do that, that's not a pap smear. That's just a pelvic exam. So I just wanted to put that knowledge out there. So yes, during the physical exam, I am looking at everything from head to toe, especially for PCOS, looking at the face, asking patients if they have any excess hair over their chest or their nipples, taking a look at that. And then while I'm actually getting ready to do the pelvic exam, taking a look at the outside, at the vulva, which is the outside of the vagina, and looking at hair distribution. Now, a lot of ladies nowadays, they will shave or wax and all that kind of stuff. So it's kind of hard to see exactly where hair may be distributed. But for some of my more natural sisters, it's clearly evident. And then actually going in with the speculum, taking a look at the cervix, making sure that there's no abnormalities there, and then doing a digital exam with my fingers so that I can assess how large the uterus is, if I can feel the ovaries. A lot of time the ovaries are not able to be felt, but still doing that exam. So then once we do all of that, then, the patient gets clothed again, and then we discuss how to move forward, explain all of those different components, what I'm thinking may be going on, and then going from there. So ordering all the labs and imaging for sure. And I think we're going to get to it. I know we're running out of time, so I will just jump into that too. So in terms of diagnosing PCOS, there's been several criteria that has been floated around, but pretty much since 2003, we use a modified Rotterdam criteria. And so that is 3 distinct things. And to be diagnosed with PCOS, you have to have 2 of the 3. So one is menstrual irregularities. So either having no periods at all or having few periods. And that is periods that come every 35 days or more. Then there's something called hirsutism, which we discussed before. So that's the abnormal hair growth on the face, chest, nipples, and pubic area. And then there is polycystic ovaries. So that can take two forms. And that is obviously seen through ultrasound. So you can have ovaries that have lots of little cysts, and the pathologic finding that we'll see on ultrasound, they call it kind of like a pearl on a string. So you see tiny little immature eggs kind of dotting the outside of the ovary. So that's one way you can be diagnosed with that. And on the other hand, if the volume of the ovary is over 10 centimeters cubed. And so you can have one or both of the ovaries with that. And like I said, 2 to 3 get you that diagnosis. Now, you can fortify that diagnosis with more labs where you're testing testosterone and either DHEAS or something called the anti-Mullerian hormone. That's a newer one that has been incorporated because research has shown that in patients with PCOS, it's actually 2 to 3 times higher than patients who don't have PCOS. So they're typically in the range of about 5 or higher. And so those are kind of the diagnostic criteria. I've talked a lot. I want to see if there's any questions.
Shannon Whiteside said, I thought PCOS was normally checked by ultrasound of the ovaries to confirm cysts and not so much blood work.
You're right, actually. So it is a clinical definition. So the ultrasound is one piece of it, like I mentioned before. So that can confirm the polycystic ovaries and or large ovarian volume. But you have to have the irregular periods and the abnormal hair growth as well to match. And that grants you the diagnosis. The labs are just extra and can help fortify that.
Okay. Here, this is a question I posed to the chat. It says, if a doctor asks you about your health history, what's one thing you will want to make sure that they know? And Doc, you did hit that. So in the chat was just going on with it as well. So I love how that they were actually interacting with that. So basically, what is one thing you want to make sure that the doctor knows? Because again, we always say that, tell the doctor, tell the doctor. They're talking about here, past surgeries, medical issues, family history. And that's one of the biggest things that you all discussed as well. History of breast cancer, high blood pressure. So we did talk about that as well. So excellent job on that. We thought Bayou said, I want them to know I prefer alternative methods before meds. So with that one, what are some alternative methods? So Dr. Coy was talking about holistic as well. So Doc, when it comes to that, because again, they're coming into you and when they see, they automatically assume you're going to be put on medication or they're going to be put on medication. So what are some holistic alternatives for that?
Well, for me, again, it's looking at testing and looking at it from the standpoint of if there's a person that is looking to address polycystic ovarian syndrome, we're also looking at the symptoms that come about from that. And it's interestingly enough, there's many links with polycystic ovarian syndrome and autoimmunity, and that can even also relate to other hormone dysfunctions like Hashimoto's thyroiditis, which is a autoimmune condition of the thyroid, and the thyroid gives us hormones too, right? And so there's many links that come about from that. And so listening to those symptoms, but also understanding that testing has to be geared toward really addressing the person as a whole. So it's very easy to just look at the polycystic issue, and that is a problem. But then you also have to look at, well, there's other problems that could be going on that are linked toward it. And unfortunately, the traditional medical model sometimes can be so tunnel vision at looking at one problem, but just missing other areas of concern. And so understanding that there are environmental factors that come about with this and that you need to really address. And we know that there are many ways that integrative medicine, functional medicine, of having that 1,000-foot view approach to look at everything and how things are related together can really help an individual to manage their symptoms, but also address those triggers of it. And obviously addressing those symptoms as you go along. So that would be the approach, and making sure that you're not leaving stones unturned, even though you see there's a definite problem and issues and those symptoms, but also address those other things. Sometimes symptoms can be categorized in severity, and I think that's probably one of the ways that patients can even marginalize themselves, where they will have 10 symptoms, but they focus on the top 2 because they're the most problematic, and leave out the other problems because they don't hurt as much, or they're not taking you away from life enjoyment or anything of that nature. So looking at all those symptoms and looking at how everything connects together, hopefully you don't miss other factors that are driving and being triggers of even the primary issues that you're looking for to correct.
Yeah, let me jump in real quick. I know when you're looking at PCOS, it's actually more of I'm trying to figure out the best way to, basically you're looking at several things. You're doing several tests. So it's not just blood work. It's not just an ultrasound. It's not just disc scan. It's actually a group of things that you're putting together to formulate a plan and actually figure out what's going on with the patient. So a lot of people like to separate when it comes to medical treatment. Well, they only looked at this or they only did that. They're actually ordering a gamut of stuff to try to rule out and rule in different things. When it comes to PCOS, me in particular, I'm looking at your blood work, but I'm checking hormone levels. I'm checking your thyroid. I'm checking your A1C, because studies have shown you're at increased chances for thyroid issues or increased chances for diabetes. And then even if your levels are low, as a primary care doctor, I'm going to repeat those levels just to monitor them, if not every 6 months, at least once a year, just to keep an eye on what could be going on or what could potentially take place further down the road.
Cool. Doc, did you want to add anything for that?
No, I think they covered it all.
Okay. So Bayou said, I apologize, Bayou, because I was going through so many chats. I overlooked yours. I do apologize. Dr. Whiteside knocked me upside the head and said, hey, you missed one. Says, please, can you all explain hysterectomy and how in young women it is basically eliminate a natural filter system? So that, Doc, could you explain that part real quick, or explain that?
Sure. So I do want to clear up one misconception about hysterectomy. So a lot of times patients will, when I'm taking a history anyway, sometimes patients will say, oh yeah, I had a partial hysterectomy, or I had a full hysterectomy, et cetera, et cetera. So when I hear partial hysterectomy, I hear that you still have your cervix, but the body of the uterus has been taken out. A total hysterectomy, to me, is taking out the body of the uterus and the cervix. Now, for my patients who say this, partial to them means that they just got their uterus taken out, they still have their ovaries, and total means that the whole shebang is gone, the uterus, cervix, and ovaries. So I just wanted to clear that up. It's actually 2 different surgeries. Taking out the ovaries is something totally different. It's called oophorectomy, and hysterectomy is strictly dealing with the uterus. So whether or not we took out the cervix, that is what differentiates it from partial or total. Now, the other half of that question was talking about filtering or taking the uterus out in young women and how that interferes with the natural filtering. I'm a little unclear with the intent with that question, but I'm not sure if my answer is going to answer that, but we do know that the uterus and the vagina itself is kind of like a self-cleaning oven. So it can express different things based on the environment that it's interacting with. So like if you have an infection, I mean, the vagina is full of bacteria anyway, but if you have an infection that's kind of overriding your natural flora, then the vagina will work hard to get rid of that. Likewise with the uterus. And so I'm not sure if I answered your question with that part, but I will say too, if young patients who have lost their uterus as well as their ovaries, that can definitely cause a lot of tremendous effects, aside from putting the patient in basically surgical menopause because they don't have the hormones from the ovaries anymore. But with that, the Women's Health Initiative study has shown that that can increase a patient's risk for all-cause mortality, meaning that they can die sooner. It can increase patients' risk for diabetes, certain cancers, and things like that. So we really, really, really try to keep the ovaries in place, more so now, I think. And there's been recent studies to show that even keeping the ovaries in around age 50 is beneficial. The average age of menopause is 51, where we assume that the ovaries shut down, but studies have kind of debunked that to say that they actually still do work for you in protecting your bones and cholesterol and other things with your health.
Absolutely.
Ooh, got a question for the chat. I think I just dropped it. Yeah, I just dropped it. So here you go. I'll post it here. It says, what do you think an ultrasound can show inside the body? So we're going to hit ultrasounds real quick. What do you think an ultrasound can actually show inside of a body? Choose one or type your idea. A, bones. B, organs. C, blood vessels. Or D, all the above. So again, using my teacher voice. What do you think an ultrasound can show inside the body? A, bones. B, organs. C, blood vessels. Or D, all the above. Or you can phone a friend.
While you do that, pull up Walt's question as well.
Okay, my bad. All right, here we go. Walt says, do these doctors that remove female body parts get profit from them, which pushes them to do surgery? So, you know what they were talking about, how organ donors, donating organs and stuff, you get the money for that. So when it comes to this, when you're removing, is there a profit with that?
Let me jump in. It depends on what's going on, and it depends on, I hate to say it, but what part of the U.S. you live in. I don't see them organ harvesting anything, but I do see that some providers will push you towards a surgical procedure that's not required in order for them to pay bills and to take it and to upcharge the insurance companies. I do see that, and that happens quite often. So kind of yes to answer the Walt question, but not, I won't say it's a large majority. I would say it's only a minority that would do it. What you say, Doc?
I would agree with that. Or what I saw in residency was that they would do the surgery. Now, I wasn't with them in the clinic when they counseled the patients and everything, but to increase the cost, they actually would scrub with multiple doctors. We didn't necessarily need all of that, or do other interventions for a straightforward procedure that, in my opinion, didn't necessarily need to be done. So it does happen.
What you see, Dr. Coy?
That's a tough one. I have to think about that one a little bit.
All right, because I'm asking for more the integrative functional standpoint, because once they go through the surgeries, we talked about it, you're going to have issues, scar tissue, uncontrollable, unexplainable pain. Yeah. And I'm wondering from your standpoint, when you see them, how do you handle, especially when they say, I have pelvic issues, pelvic problems, pelvic discomfort?
Yeah, I mean, obviously, if they've had a surgery or they had a procedure, I'm always looking for them to go back and make sure that they get evaluated from a medical standpoint. I think that's the responsible thing. And while they're doing that, obviously get the testing that they need that is going to give or paint the best picture surrounding that. But if there is a procedure or some type of even with medication or hormone replacement, that's the thing that also we have to consider as well, is that if they're given they've had something taken out and they're replacing it with some type of hormone therapy, there could be interactions with that. And so that has to be looked at as well, because every medication is going to give some type of side effect. And and we have to take that into consideration as well. So evaluation, reevaluating the process, the plan of action. Sometimes it may require them to go a little earlier than their designated checkup that they had scheduled. So I think that's I'll send them back.
Okay. Anybody else? Sorry. Okay, my bad. All right. So it says, what do you think about ultrasound when it comes to ABCD? So we have Urban. Urban says D as in dog. Shannon says organs. Ms. Edwards talks about letter B as in boy. So from you all perspective, again, I'm not in this when it comes to this. So what exactly does an ultrasound truly show?
It depends on the kind of ultrasound you order. Ultrasound will not show bone, but it can give you organs depending on which specific organs you're looking for, and it can give you blood vessels depending on if you're ordering the ultrasound to look at blood vessels such as DVTs. So I would say B and C. It's just based on really what we're looking for in particular.
Okay. So with that, we're going. Oh, go ahead. Go ahead, Dr. White.
No, I was just going to say, it's going to look at your organs. It's going to look at your tissues, blood vessels, primarily. What you're really looking for. You're really looking at the soft tissues, primarily for those things.
Mm-hmm. Doc?
Agree with all of that.
Agreed.
We don't get ultrasounds to look for bones, but
right.
Yeah.
In fact, I mean, a lot of times, ultrasound is a therapeutic treatment as well, right? Mm-hmm. So there are different frequencies of ultrasound to be able to for either for diagnostic purposes, but is also a treatment purpose that sends sound waves into those tissues to help break up cavitations and sort of increase circulation and those things like that. But from a diagnostic standpoint, you're really looking at soft tissue imaging.
Okay. Since we're talking about ultrasounds, have you chat? Yeah, you don't have to answer if you don't want to. The HIPAA violation, I don't look good going to jail, so I can fight 1 or 2, but when you get 3, I'm done. So have you, in the chat, have you ever had an ultrasound before? Again, it can be any type of ultrasound. So thumbs up if you had, thumbs down if you haven't. It's okay if you don't want to answer. It does not bother me. But one thing I do want to ask, Doc, when it comes to this one, when I was doing the research, I noticed that was one thing you saw that too. And like I said, I'm not familiar with this. There was 2 types of ultrasounds. You had abdominal ultrasounds and a transvaginal ultrasound. Again, I mean, I know the plain simple. Could you actually explain the difference between those 2? And I guess, is there one that's better than the other one?
Yes. So all my ladies who have had an ultrasound, you definitely can tell the difference between the 2. So
yeah.
The abdominal ultrasound is exactly what it sounds like. It's on the abdomen. Depending on the type of ultrasound you have, the images may not be as clear as they are with a transvaginal ultrasound. At my first duty station at Andrews, I think we had ultrasounds that were like pushing 20, 25. So there was not much that we could see on the abdomen. And then if we're talking about patients who have a little extra fluff, it can make it more difficult to see the structures that we need to see unless they are really large and in our face. Transvaginal ultrasounds, on the other hand, can definitely give us a lot more detail. A little less comfortable for the patient, but we can see with a lot more clarity the uterus, the lining, the ovaries, and things like that.
Okay. So now I know I'm going to jump ahead into that. When it comes to that, transvaginal ultrasound, again, for that one, like you said before, so you're able to get a better picture of the actual cyst. When you're doing the ultrasound like this, are you trying to count the number of cysts, or are you trying to see if it's just a large amount?
So some providers can count But in all of my years, I've never read a radiology report where they count the number of follicles. They'll just say numerous immature follicles present on the exam. Now, what they do is include the volume of the uterus, which to me is very helpful because sometimes patients don't have a whole lot of cysts that show up. But if their volume is over 10, then I say, okay, well, they have one of the criteria for PCOS. But sometimes they do. As in the previous slide, in terms of diagnosis, for it to be considered PCOS, you have to have 20 or more immature follicles that are seen. Like I said, I haven't had them counted. They just say lots of follicles, but it's pretty impressive on ultrasound when you do see it.
Okay. Now, question, because I know you said the volume. When you say the volume, are you talking about the uterine lining when you say volume, or what exactly do you mean?
The volume of the ovary.
The volume of the ovary. Okay.
Yes.
Okay. I mean, I know I had that, but somebody else may have had that question as well. So another question, because it may pertain to this, and it deals with the treatment as well. We can jump to the treatment real quick. So when it comes to this part, and like people, women with PCOS, is it common? Because we talked about it before, having irregular menstrual cycles. So sometimes it may be heavy, or maybe light. Is it common for them to have a thicker lining of the uterus, which causes the heavy flow? And if they do, is it common for it to go on longer than the typical 7 days?
So I would say to that, yes. What I tell my patients is that the thing that we get most concerned about, especially with patients who have menstrual irregularities where they're not having a period for 2 to 4 months at a time, or they're not having a period at all, is the health of the uterine lining. So essentially the way that I explain how PCOS affects them is I will draw basically a cycle on a piece of paper. And so at the bottom, I'll have day 0 or day 1, which is the first day you start bleeding. I'll have an arbitrary middle number, and then I'll have the end. And so there's 2 phases to the cycle. There's the proliferative phase, which is the first part of the cycle after you start bleeding. And then, there is the follicular phase. That is the first part after you start bleeding, where your ovaries are recruiting different cells and one becomes more dominant. And then that's what gets released when you ovulate. And then the second half is the proliferative phase, where the actual uterine lining is getting ready and mature to receive a fertilized egg if that happens. In PCOS, because I have PCOS, we typically stay in the first half of our cycle. And so that is where the uterine lining is growing under the influence of estrogen. And so if you think about it, if you're not having a period and you're staying in that cycle, it can get thicker and thicker and thicker. And what we get really concerned about is that over time, the lining of the uterus can change and become something that is precancerous or even cancerous. And so my primary concern is making sure that we are addressing the uterine lining with different modalities. And so the first thing is definitely pushing lifestyle modifications with diet and exercise. As it's mentioned here on this slide, a reduction in as little as 5 to 10% of a patient's body weight can actually regulate someone's cycle. And so that is first line. Now, can we do that in conjunction with other things? Absolutely. But that is the number one thing that I tell my patients, like, hey, we need to do this. Sometimes I will have them go to nutrition as well to kind of talk through how best to eat to achieve weight loss and to maintain it, because those are really the hardest part. Get started losing weight, and then how do you maintain that? Because diets can only last for so long.
Dr. Coy?
Yeah, I mean, as far as what's shown here, these
This one?
Oh, you're going back. Okay. So obviously, yes, the dietary recommendations, of course, lifestyle. So I'm always looking at 2 components to health and wellness is, you have your lifestyle that includes, how you're sleeping, what you're eating, stress management, the different other stresses that go on that we have immediate control over. But then there's the environmental factors as well. So finding out what are those environmental factors that are driving dis-ease. And so the combination of the two can come about. Some folks, they may have food sensitivities that they haven't been aware of, or they're ignoring. So you want to be able to find out that pertinent information to customize a plan for them to make sure that they're eating the right things to not proliferate insulin resistance and more inflammation by their own doing. Exercise, in many ways, can be helpful, but sometimes that can also be a stressor to some individuals. So, it's very individualized in my opinion, that you have to look at the type of exercise, the intensity of that exercise. Sometimes exercise is not a good thing. And so you moved on to the next one. A lot of times where I'll see patients, because they have that insulin resistance and they're in that, the PCOS can mimic diabetes and pre-diabetes. They're already put on metformin. And the thing that I always look at is, well, what are the side effects of metformin or even these GLP agonist medications? Metformin can oftentimes cause B12 deficiency. And so there's going to be some symptoms as a result of that can relate from issues with poor digestion, all the way to a headache, to all the way to to having these issues and symptoms that come about from that. And obviously the GLP agonist medications like the Ozempic and those things, I would say really be careful with the side effects. They've been able to cause issues like gastroparesis. And so when you're shutting down your ability to feel hungry, or slowing down your level of digestion, that is going to cause more and more problems down the line. So that short, to lose that 5, 10, 15 pounds, is it worth sacrifice that for the symptoms that you're going to have as a result of that? So I think you have to be well informed, as the doc said. Okay, that's a good question. Yeah. Are female issues also treated with detox, parasite cleanse? Are cysts not also parasitic sacs? Don't know about parasitic sacs, but I would tell you that when you do panels and really look at blood work and those symptoms and looking at their health history, you'll be surprised on what you see. You'll be surprised on the person's health history, that many times these things are misdiagnosed or just pushed aside. Here in the United States, many people have parasitic infections. They don't even know it. You don't have to live in a third world country to have parasites, and that's just another form of an infection. So it's important to really look at not only your blood panel, but also even sometimes we do stool tests. We find those parasites in the stool, in the GI tract. That's going to cause inflammation. That can cause insulin resistance and all these hormone imbalances as well. So it's important to not ignore that.
Absolutely. And I would say that cysts, particularly in the ovary, for the most part, they're not. If we're talking about polycystic ovarian syndrome, those are immature cells, immature eggs, I should say, excuse me, that potentially could turn into a dominant egg that gets released during ovulation. So I wouldn't say they're parasites in that regard.
Right.
Okay. Doc, did you want to hit on anything about this before we move on to the next slide?
Sure. So aside from lifestyle modifications being the first line treatment, in terms of medical therapy, first line treatment is a combined hormonal contraceptive, either via the pill, the patch, or the ring. There is one brand of birth control pills on the market that has been specifically associated with good outcomes in patients with polycystic ovarian syndrome, and that is called YAS. It does have a slightly more increased risk of blood clotting as compared to other formulations of birth control pills, but it's pretty minuscule, but not necessarily dismissing that, but I do counsel my patients about that. And so those hormonal contraceptives can help with regulating the cycle. So again, protecting the uterine lining, lowering the androgen levels, so helping to decrease some of the facial hair, chest hair, pubic hair, and reducing acne as well. There's other hormonal options. So for patients who are not able to take estrogen, there are progesterone only options. And again, if our primary goal is to protect the uterine lining because there is no period or the periods come so infrequently, I would take those options all day. Now, will that necessarily help with the cysts? No, but we are protecting the thing that potentially could cause a greater problem in the future. And so those include things such as the progesterone-only pill, progesterone-only IUDs, Depo-Provera, which is not my favorite. That's a whole nother talk for another day. Or the implant, which is the next one on. The other modalities are also treating specific symptoms associated with PCOS. So the spironolactone is more so for excess hair growth, metformin, for diabetes or insulin resistance, can even been utilized in patients who have infertility to help them ovulate, and then the GLP-1 medications.
So looking at this right here, so we talk about fertility treatments. You got a Clomid, how you say that? Letrozole, yeah, that one.
Mm-hmm.
IUI and IVF. IVF. So can you expand upon these a little bit?
I can. So historically, actually, let me back up. So Clomid and Letrozole, those are what we call ovulation inducing medications. So for patients with PCOS who are having no or few periods, the problem is that they are not ovulating. So they're not getting to that point in the cycle where there's a hormonal surge and the mature egg gets released. And so these medications help that process to happen. Now, historically, Clomid was actually the first line treatment for patients attempting to conceive. And so, however, Letrozole has actually been shown in studies to be more effective than Clomid and reducing the risk for multiple children. Clomid does carry that risk. And so those can be used in isolation. So you typically would take them within the first few days of starting your period. And then theoretically, you would have a normal 28-day cycle. So you would anticipate ovulating around day 14. And that is when you want to concentrate your intercourse. Now, like I said, they can be used in isolation or they can be used in concert with intrauterine insemination or IUI. And so what typically will happen is you take the letrozole in the beginning of your cycle. This is all done under the supervision of a reproductive endocrinologist. So they typically will monitor you those first couple of weeks with scans to see how your eggs are developing, which one is becoming dominant. And then they typically will either give you a trigger point shot, which will actually trigger ovulation, or just follow your hormones and say, okay, this is the day. They have you come in, your partner will give a sample, they spin it down, they get it into a really concentrated vial. And then once you're ready, you get set up like you're getting a pap smear, and then they basically shoot the sperm into the uterus. And so that kind of gives them a head start to bypass the vagina, bypass the cervix, and really get into the area where they can hopefully fertilize an egg and help you to get pregnant. Personal story about that. So like I said, I had PCOS. Me and my husband, we had difficulty conceiving. I think we tried for 2 years without any help. And I had used letrozole for pretty much all of my cycles for about a year and a half. And it didn't work. So I used the lowest dose to the highest dose. Lowest dose is 2.5, highest dose is 7.5, still nothing. We moved on to the IUIs, and we did 3 or 4 of those that did not take. I did get pregnant once, but it's kind of hard to say whether or not it was on our own or with the letrozole because of how the testing shook out. Nevertheless, that was a miscarriage. And so then I decided, you know what? I'm done with this mentally. We're just going to wait. We'll do IVF in the spring and March. And then lo and behold, we got pregnant on our own. So that could happen, but I do have experience with doing the letrozole and the IUIs, and was on my way to IVF, but we didn't quite get there. Now, IVF is a very unique procedure in that the actual fertilization process happens outside of the body. So like an IUI, your partner does give a sperm sample, and the endocrinologists take that. They actually harvest your eggs from you, and then they put the sperm and the egg together in a petri dish, let it grow, and then they actually insert that back into the uterus for implantation. And so very costly procedure, but for some people it is effective. And you would think with these type of procedures, the success rate would be super high, like over 50%. It's really not. It's like 15 to 30% per round. And so if you think about the money that you're paying for those things, it can be a bit discouraging, but if you have that dream to conceive, it can happen for you.
Okay. Here, so basically how to help someone with PCOS. So you have your understand PCOS and its effects, to the right, encourage healthy lifestyle choices. At the bottom 3, exercise weight management, what we talked about before. Number 4, provide emotional support. Again, as guys, if we know somebody or a loved one is affected by that, that's one thing we do is provide emotional support. Be there with them. Listen, don't judge. It's one of our biggest things. Celebrate the small success. So that's one of the things that we constantly forget is celebrating the small things. So we need to celebrate that. Encourage self-care. Appointments and treatments. Attend appointments with them is one of the biggest things to do. Now, as a guy, important considerations in the bottom left corner. Do not offer unsolicited advice or opinions. Yeah, guys, we're bad for that. Sorry, I'm bashing us, but we're bad for that. Well, have you tried this? Have you tried this? We're guys. You just shut up, sit in the corner, and just support the significant other. Respect boundaries and focus on the positive. So those are some things when it comes to how to help somebody with PCOS. Now, one thing I'm going to pose to the chat, and this is also, wow, leave me alone. Why you leave me alone about that? All right, so this is one thing I'm going to pose to the chat, and I'm actually posed to all 3 of you all as well. Is a very interesting, thought-provoking question. How do societal views about women's health and reproductive issues influence how early or how often these conditions are diagnosed? I know you got to read that one again. It's like, what? Read that one again. It says, how do societal views about women's health and reproductive issues influence how early or how often these conditions are diagnosed? So with that said, chat, feel free to drop it in. And doctors, panel, y'all take it away. Whoever want to go first.
Let me jump in real quick.
Oh, here we go.
That's, I want to say it's almost a couple of different. Shut up. A couple of different reasons. Boy, it's looking like women are going longer before they start having children. So from a societal view, I think it's more of that, and then just the male dominant society trying to dictate women on when they should have kids, how long they should wait, if they should or should not. I see that's part of the influence. And the other influence I see is just the insurance companies. Insurance companies do limit what we can and cannot do. And that alters our treatment plan as well.
Okay. Docs, either one?
I would agree with that. Now in the military, we don't necessarily have to fight with insurance, so I think that's a plus. But thinking back to my residency days, there were definitely times where we had to fight with the insurance company because there was a certain algorithm that they expected us to follow instead of following what the patient dictated. And so that definitely can play a role. And I think along with what Dr. Whiteflat was saying, just societally, patriarchy, all of that kind of stuff playing a role, definitely in this climate where we are, where, funding for certain things are getting cut or are deemed not as important. I think all of that is can play a role as well.
Dr. Coy?
Yeah, from my perspective, usually when a person or a couple are looking for, well, let me back up. They're looking for alternatives. Mm-hmm. That's when they look to me. And so that's where my view comes into play. And so it's a little different when it's when you're looking for something, you find it, right? You're looking for an alternative. You're looking for another way to get to the goal that they're looking to achieve. And so they're willing to do what it takes. They're looking to make the changes. They're looking to, from chiropractic care or to physical therapy, they're looking at, nutrition. They're looking at meditation. They're looking at stress management. They're looking at multiple things as an alternative to get to their goal there. So I think for me, it's really, they're really trying to find answers. They're trying to find answers beyond what they've been told by the traditional medical model. Okay. So they're sort of mavericks, so to speak. They're looking to think outside the box.
Okay, so I'm going to backpedal real quick. This way, we're talking about 70%, and of that 70%, we talked about undiagnosed cases and the different studies. One thing, I want to pose this question to the chat as well when it comes to this one here. It's talking about, did I post it? There we go. This question here says, how might barriers like costs, access to care, and cultural stigma affect a person's ability to receive timely and thorough evaluation? So again, this is for the panel as well as for those in the chat. I'd love for you all to chime in with that. This is just thought-provoking questions, something to think about. Because again, that number 70% is large. Potentially up to 70% of women with PCOS may not be diagnosed. Why is that? And this question pertains to that. So the chat as well as docs on the panel, take it away.
I think for all of those reasons, all of those things significantly affect how a patient is treated, if they can even get to the doctor, if they have the means to get to a doctor. So we put things like cost aside. We know that healthcare is extremely expensive in our country. Couple that with deductibles that sometimes have to be paid before the insurance kicks in. But also access to care. So is there a physician in the vicinity? Okay, if there is, can the person even get there? I have evolved because, sometimes I would get frustrated in residency in an urban environment where some of my patients weren't able to make like their OB appointments, et cetera, et cetera. And then, becoming more educated and figuring out, hey, they might not have access. They might not have anybody to watch their children for an hour for them to make it downtown so that they can get to an appointment, et cetera, or all of the hoops that they have to jump through just to get there. And, expanding my mind to say like, you know what, everybody does not have a car. Some people may have to take public transportation, et cetera, et cetera. Additionally, it depends on how people are raised as well. And so there are I'm sure there are certain cultures and ethnic groups where, they just take care of it in-house and don't necessarily go to the doctor. Or doctor mistrust is also probably a big thing that plays into mind, because either they or someone they know and love has experienced a bad physician, and they're like, nope, I don't even want to be bothered.
Dr. Coy?
Yeah, I mean, it's hard for me to add on to that, but I do see that insurance can play a major role into whether or not a person is going to get the care that they feel they need. And of course, that's with different types of insurances, deductibles, and services that are being administered. That definitely can play a role right there. But either lack of education, resources is going to play a role in any condition, to be honest. So, but oftentimes the insurance can be a big hurdle with getting the care that a person needs.
Okay, cool. I know we're going on an hour and 40 minutes. This is one of our longest chats, but I want to bring some of this up as well, because I love how the chat is actually chiming in. Thank you for doing that. We love crowd participation. Just dealing with the issues is normalized. Okay, which makes sense. Just dealing with the issues. Here, why you say here in Arizona, there's hospitals specifically for Native Americans because their approach is different from conventional medicine, which makes sense. Holistic medicine. That's one thing I think Urban was talking about. We're doing holistic medicine, not actual modern day medicine, dealing with medicine itself, medication itself. Those who live on reservations travel miles just to be treated. Urban here says finding a female doctor was difficult, as most don't feel comfortable having a male doctor doing pelvic exams. Even tech doing scans we need for females definitely affects culture and religious groups. True. I'm not disagreeing with that. True. How do you feel about that, docs? Well, I don't know what Dr. White said when he just disappeared. So how do y'all feel about that?
I definitely can see that. With different cultures and things of that nature. There's, some cultures, the male or the husband has to be in the room with their partner. And so there are multiple cultures and multiple things that have to be considered. So I definitely agree with that.
Dr. Watson?
Dr. Lyons, I'll let Dr. Lyons.
No, they go Dr. White. Okay. Well, I guess
it's dinner time here, man. Come on, work with me.
Either way.
No, I agree as well. I can't tell you how many times that I've had patients request female-only physicians, and luckily I was there. Otherwise, they would have been with 3 of my male colleagues, and so that definitely can be a barrier.
I would say, as a male doctor, I don't like doing pelvic exams. I'll let you know. Some women have that misconception thinking, oh, this guy, he's going to look down. He's going to do. No, I'm not trying to be funny. It's utterly disgusting. It is. From the standpoint, it's not what some women would think, oh, he's going to look at my vagina and just start thinking all these thoughts. No, as a male provider, when you're going in, you're actually going in for the exam. You're looking inside, trying to figure out stuff. So, but it's not something that's enjoyable. And then the female patients I have, they requested me, but also as a male provider, I let them know this is what I'm gonna do. I have my female chaperone in with me, and I'm trying to figure out the easiest way. When I was taught to do pelvic exams, I had a female gynecologist say, sorry being graphic, think about it as in when you're going in using a speculum, you have somebody that actually have your testicles in their hand. And when the women flinch, they're twisting and pulling on your testicle. From that standpoint, my exams are flawless. There's no pain at all, but I just don't like doing them. It's not fun. It's not what people would think a guy would think is one of those enjoyable type exams. It's not.
I ain't got nothing to say about that. I mean, I'm like, Derek, you say there's no pain, but you're not the one. You're not the one receiving the exam. So how do you know?
Oh, that because when I'm doing it, I'm asking the patient at the same time. The goal is not to put them in pain. I mean, I would say it's almost equivalent to having dental work done. No, a lot of people don't like having dental work done. My goal is to, as a male provider, because usually males are rougher, you will think. But from what I found out from the female patients, that the females are a lot rougher because they're saying that the female provider is saying, well, deal with the pain, deal with this. A male is actually going to be gentle because he's scared, in my opinion. But I know for me, I'm scared. I'm going in. I'm trying to go in, do what I got to do, and get out. I'm not trying to hang out down there.
Oh, we got Dr. Watson. Go ahead and let it out.
First of all, nobody's trying to hang out down there. That's number one. But number two, I think, men or women, they can be kind of rough. And so it definitely helps if you have that gentle touch and empower the patient by informing them what you are going to do. Like, here is me touching your leg. Okay, now you're going to feel this. Here's the speculum. It's probably cold. I'm sorry. You're going to feel some pressure, et cetera, et cetera. And I always tell my patients too, if at any time any of this is uncomfortable, you can tell me no. You can tell me to stop, and I will stop. Because again, like Dr. Whiteside said, we're not in the business of hurting people. And so, people bring their full selves to the visit, whether they express it or not. And so I'm cognizant that some of my patients may have experienced trauma of a sexual nature or otherwise. And so it is very important to, talk things through. But again, nobody is trying to hang out down there or, do different things. We there for a job. We just looking and getting out of there.
One question. I had to make sure my mic wasn't muted. All right, one question here. So this is very interesting. Women who have PCOS, if they had a C-section, because again, we understand they cut the abdominal muscles. So if they've had a C-section, but they suffer from PCOS, why do they tend to have more abdominal pain during their menstrual cycle?
So that could be due to a couple of reasons. One is a C-section is a major abdominal surgery. So after any type of surgery, you're going to have scar tissue, no matter if it's a lot or a little bit. We never know unless we're going back inside. And so at the time of your cycle, depending on if you have scar tissue and where it's located, at the time that you're having your period, your uterus is cramping to kind of push out the uterine lining, as well as to control bleeding as well. And so if it's contracting against some scar tissue, that can cause extra pain. Additionally, patients who have had any sort of uterine instrumentation, such as a C-section or a myomectomy, which is removing fibroids but retaining the uterus, or even a dilation and curettage, which is a surgery that goes in and can sample the lining of the uterus. Something called adenomyosis can occur. And adenomyosis is essentially endometriosis of the uterus. So the lining of the uterus actually migrates out into the muscle of the uterus and causes these little cystic implants of the lining. And so those implants actually respond to your ovarian hormones through your cycle. And so once you have your period, these cysts can make your uterus irregularly enlarged. And so when you're having your cycle, again, your uterus is clamping down and cramping, trying to push out the products, but also trying to control that blood flow. And so if the uterus is irregularly enlarged like that, it does it more forcefully. And so that can cause more pain as well.
Okay, good. Makes sense. Dr. Whiteside, Dr. Whiteside over there eating something. So Dr. Coy.
Yeah, I have nothing to add to that.
Okay. I got just a general question. Okay. I'm trying to be good. General question. Why is that during the menstrual, females crave sweets or chocolate? Because I teach healthcare and I teach a lot of females, and it's coming to the end of the school year, and now majority of my females' cycles are starting to sink, and I'm already going bald because they're stressing me. But why is that? What's the reason for the craving? I know it's just it doesn't pertain anything to PCOS. It's just me just wondering.
That's a great question. And you know what? I had that exact question and I looked it up and I forgot the answer. So I'm just being honest. But it is a thing. It is a thing that I have looked up. I just cannot remember, y'all.
Yeah, I mean,
ChatGPT for me.
a lot of it is again the vitamin and mineral deficiencies
Okay.
that are related to that.
Mhm.
So, when you're having a lot of these cravings and these hormones, and you're having issues with again trying to have energy. The body is craving certain nutrients because you're losing them. A lot of the magnesium, you're losing that. A lot of times you're having the cravings for chocolate. If you're having low energy, you're having these sweet cravings. So the body is always telling you what you're needing or what it's calling for. So the key is not to go overboard with it. So a lot of times, supplementation is needed to help curb those cravings, to be aware of that when those times comes. Sure.
Okay. Like, look, because in my back room, I got chocolate. It's like, you get on my nervous system, chocolate, leave me alone. And enough said. We got to understand it now. So it's like, here's your chocolate. I don't care. I already know what's going on. Here's chocolate. Leave me alone. Sit down. Be quiet. So I'm trying to be a little more sympathetic, but yeah, it ain't working. I'm trying.
Right.
Oh, are you? What did she say? She said, yeah, my monthly creates a struggle for me when trying to eliminate cravings with fasting. That does make sense. And that goes exactly along the lines what Dr. Corey was talking about. The deficiency, especially when it comes to the cycle and the blood loss. So you had the deficiency when it comes to that part. In addition to that, you have to factor in. For me, I freeze all my students. So I just tell them bring a blanket or bring a big jacket because it's gonna be cold. And Carbon's talking about serotonin levels drop. Ooh, good question. So what does that mean when they say serotonin levels drop? Either one of y'all. I know we're going almost 2 hours, so I'm trying to wrap it up, but these are good questions. So serotonin drop, what does that mean?
Yeah, serotonin is your happy hormone, right?
Okay.
And so, in a lot of these things too, a lot of these hormones are in the gut as well. Not just, they're not just neurotransmitters that are found in the brain, but they're found in the gut. So, it's amazing how, the microbiome in our gut is going to also give us indications of hormones that are either deficient or we have a resistance with. So if we are not feeding ourselves the right things, it's going to change the ecosystem of our gut. And so it's very, very important to recognize that if there are cravings, they are deficiencies. There are deficiencies, or just there's some imbalance that's going on there. The key is not falling for your cravings in a bad way, but to fulfill it in a good, healthy manner. So I think that's the key there. So when you have these, when you call serotonin and all these other these neurotransmitters that are dropping or imbalanced, you just got to make sure that you recognize what that is. And then even with the serotonin, you'll figure out, hey man, you have these issues with brain fog, or you have issues with anxiety, depression, and all these other symptoms. These are just symptoms that could be as a result of those imbalances.
Right. Anybody else? Oh, anybody else? Look, y'all, I forgot Derek ain't here no more. He eating. Doc, did you want to add anything to that?
No, I agree.
Okay. Hey, what up, Doc? Welcome here. Noah Armory Medical. That's Dr. Brian. Oh, Derek, be quiet. That's Dr. Brian. Oh, all the way down in Louisiana, the Bayou. So welcome. Thanks for joining us. All right, so it's going on an hour and 53 minutes. Don't want to keep everybody too much longer. So these are just some resources. PCOS Awareness Association, Jean Haley's, I think is what it's called. Conquer PCOS, PCOS, and PCOS Sister Telehealth. Now, Dr. Watts, because again, like I say, this is your bread and butter. Is there any other resources that we can actually reach out to, or that the chat can look for to help with PCOS, or someone they may know going through PCOS or has PCOS?
I think all of the resources that you have there are good. I really like to caution people away from Googling things just because it's hard to vet their accuracy. But if you do Google it, I would say looking at resources from reputable sources. So like if you Google a syndrome or something like that and Mayo Clinic pops up, or something from any university, I think those are pretty good to get kind of like a high level view of something. You can also go to the ACOG website, and there are resources there for patients as well. That's www.acog.org. And there's lots of different topics on there geared to patients that are helpful as well.
One question before we end it, sorry about that. It says, exemplary consulting talk about, does exercise help during the menstrual cycle? So we did talk about that again, the drop in blood, so more fatigue and things of that nature. So does exercise, and talks about, some say is more damaging than good, but does it help during menstrual exercise? What are y'all takes on that?
I think it's again the individual. It's the individual. So if it's causing more symptoms and more problems, then I would say do not exercise. Mm-hmm. Exercise is a common modality that's used, but sometimes it's not good for that individual at a certain time.
Dr. Watts?
I would agree. It definitely varies from person to person. If you exercise, could it potentially help with your cramping? Yes. Again, but it's individual. So like for me, for instance, my periods were, but in college I played basketball. So if I went to practice, I actually would feel a little bit better. But again, it just depends on the person.
Okay. Yeah. As long as because I coach female track, as long as they don't hear this, they're going to run regardless. So I was just going to run. I don't care. But no, in all honesty, seriously. So that was actually good. Thank you all for joining us for this chat. Again, this was one of our longest ones, going on 2 hours, hour and 56 minutes, 21 seconds. Thank you all so much. This is one of our best chats we had. I mean, thus far, one of the best chats we had. We did. Derek, going somewhere. Go back to eating. We don't care what you know more. Go back to eat. So yeah, and Dr. Wise, thank you for joining us for this, because I love the interaction. This is your bread and butter. So for you to give the expert input, it was perfect, spot on. Dr. Coy added that with the holistic medicine, because we have people from both dynamics. One that loves the urban medicine, one that wants the holistic. So I love how you are able to interact and feed off each other and get two different perspectives, but actually come to the same common denominator, which is the patient's health that we focus on the most. So I love that. Dr. Whiteside, thanks for joining us during your mealtime once in a while. With a thumbs up. All right, so with that said, thank you so much, chat. If you all could do us a favor and give us a thumbs up and share this, share this video with people, like I said before, with your friends, family, even your frenemies or enemies. They may be going through PCOS. Give this to them or share it with them so they know, so that something is an extra resource. Again, it's an extra resource. Like we always say, always seek your medical provider, but this is just a resource. Again, pay attention to the medical disclaimer at the bottom. It's for educational purposes only and does not substitute professional medical advice. Always consult your primary or licensed healthcare professional when it comes to this. And with that said, we'll let Dr. Watson get the last word. So we get Dr. Whiteside, get him out the way. Whiteside, you got anything to say? Nope, moving on.
No, I don't. No, I appreciate Dr. Coy and Dr. Lyons for joining in, helping out with this. I was chatting with Dr. Lyons backstage, just trying to figure out if we're able to link up with her schedule to get her on for possibly another talk. I had to work with Eric to figure out something else. I was thinking of endometriosis or something along with pelvic disorders.
Okay. Dr. Coy?
Dr. Coy Ibrahim, Coy Wellness Solutions. Find me on Instagram, Facebook. Of course, we are here to help individuals to get to the root cause of chronic disease. I love this topic because, you know, it's talking about lots of hormonal issues, and we look at those things and test it, but just making sure that we're not staying tunnel vision on one specific thing. We want to make sure that we treat the whole body and address the root cause. So thank you so much for having me once again. I made it.
Hey, last time was a slip up. It's all good. It was all good.
Yeah.
We held it down. We struggled through it.
Yeah.
Derek left me a few times, but it's all good.
Oh,
I ain't Dr. Whiteside. I'm Mr. Whiteside, Whiteside Tech Solution Med Inc. If you're looking for any type of first aid, CPR, ACLS PALS, or any medical emergency preparedness training, feel free to hit us up. We're there for it. If any of you all looking to research, you know where we are. Just drop a line at www.whitesidetacticalsolution.com or email us at info@whitesidetacticalsolution.com. Derek, leave me alone.
Sound like an
Hey, I
infomercial.
was going to be a radio DJ. All right, with that said, Dr. Lyons, you take it away.
First of all, I want to say thank you all for having me. I really enjoyed this. I love getting to interact with patients and really talk about a topic that I am passionate about. I am pretty low key. I'm on Instagram, but I'm a lurker. I don't put out any information, so I don't know that it would be fruitful for me to say where I'm at. But I look forward to coming back and sharing with you all soon.
With that said, it's top of the hour. Is 2 hours. It's 2 hours. It's also 10 o'clock Eastern time. That would be what 7 o'clock, 7, 8, 9, 9, 7 o'clock Pacific time. Is that correct?
Yes, sir.
Okay. With that said, thank you all for joining us, and you all have a good one. Until next time, see you.